So so if we can get the speakers up for the quick panel, the speakers for the session. So, Dr.Goichi, okay.
How many chairs do you need? I think this is good. Okay. Just share the mic. Okay. You just put it close to the mic. Okay.
I have a question for Simon while we're gathering. What are your thoughts on the 2 new implants that New World Medical is releasing or studying?
You mean the M3? That's the one, or is anything newer than that?
Yeah, there's something called ClearPath that actually didn't have to go through the FDA, didn't need a human study. And then there's something entering human studies with, still 184 millimeter square, but a lower profile and the D-shaped tube. I just didn't know if you know anything about those.
Don't know too much about that, but I was involved in when they tried to design the plate, the flow resistance element. I don't think, well, it need to be studied to know what's going on because it's pretty complicated in terms of the design in the mechanism over there. There's a lot of theory behind that, but I think the result of that will probably be either similar or sometimes not as good because remember this M3 that with porous structure of the implant, and nobody really using that anymore because thinking that it will kind of incorporate the tenon tissue or the fibrovascular tissue in that you can get a much better grab. It just turns out to be, theory. Yeah, more fibrosis than before.
Question over here.
Anybody on the panel would mind about commenting about shunt that's been around a while, and it's placed ab externo, not necessarily the way it was approved by the FDA, but under a half-thickness scleral flap.
I tried it. I didn't think it added anything to my trabeculectomy. I was putting it under the flap. But I do think that it's an easier operation to perform. I find the trainees really prefer it because it saves you from having to do the punch and the iridectomy. And I don't think we're seeing nearly the erosion rate than when it wasn't under a flap, but there's still erosion because you have that foreign object right at the limbus. I don't think the results are any better. The clinical trials, I think that Peter Netland did, don't show any better results with Express, but do show maybe less hypotony in the early post-op period. So it may be marginally safer immediately post-op with similar long-term results and certainly a little easier surgically. Brian, what do you think?
So yeah, I agree with Don. I tried it when it was first out, and have largely abandoned it. But I think the advantages were that you have better chamber stability during the surgery. So unlike doing a sclerectomy with a Kelly punch and a large opening, you get better chamber stability. So it may be less dangerous in patients with high myopia and kind of soft sclera. Additionally, you don't have to, unless the angle is narrow, you don't have to do an iridectomy in many patients. Okay, got it. But I stopped doing it for 2 reasons. Number one, I think there's the risk of erosion, which is even done under a scleral flap, we do see erosions of these devices. And the other thing that I didn't like about it was when I was doing needling. When I do a needling, intraoperatively, I like to get in there and actually go under the flap and into the anterior chamber with the needle. And I found that with that device, you just can't do that. You have to go under the flap and kind of hope for the best. And the other thing is that the device does not have a flow restrictor in it. So you're still reliant on your trabeculectomy flap and the sutures and how much flow to determine how much flow you're going to get. Unlike the newer implants, the Zen and the Infocus, which are designed to take the flow component out of the surgeon's hands. It's just a standardized flow.
Dr. Kampamajin.
Thanks, Alex. Quick question for the panel, but specifically based on Dr. Law's presentation. With respect to putting the tube under a flap, have you had any experience on posterior erosion of the tube through the residual scleral bed?
Uh,
Yeah, I think so, not yet.
So so far, no, but it's quite possible. You dissect 4x6 flap, so it's pretty not that much different from a trap flap that you dissect. So even though erosion, I hope that it's not going all the way back to the retina, that you have to find the retina surgeon to retrieve something.
So here's a question for everybody. It's something that comes on for really all the talks. I mean, what's the deal with tenons? Okay, some people will do tubes, super tenons, infratenons, and then there'll be the Zen and stick infratenons and super tenons. I mean, can you really do that? Number one, and then number two, I mean, what is tenon somehow a problem for all of this? Is it a unifying issue?
I think the tenon is more than just the tenon. Each patient is kind of individualized. Some patients has a lot of tenon tissue. Some patients have a lot of aggressive proliferation. And ahead of time, before the surgery, you may not be able to know that. And I still like the thing that Dr. Martino's study, there's a proliferation all the time. There's a degeneration all the time. That's how we function in life, that as we get younger, we have more proliferation. Maybe as we get older, we have more degeneration. So you just have to adjust according to that. And that's why glaucoma surgery can fail. And so we just have to think ahead of time, including the expression, including everything that we have.
Yeah, I mean, I think tenons is bad. Tenons is it's a sponge filled with fibroblasts, and so it's a perfect milieu for fibroblast proliferation and scarring. In some of the revision cases, I'll do a limited tenonectomy as well, just to remove some of that tissue.
Just Alex, in response to your question, I think one of the things that we underestimate actually is that when we're doing these procedures, there is a resistance to outflow, and the barrier is our external layers, both the conjunctiva and the tenons. And all of us know if we're operating on someone with very thin conj, we'll naturally tie it tighter. If we've got somebody who's got loads of tenons, either we'll do a tenonectomy or we'll be able to get away with a looser flap. We might deliberately loosen the flap just to ensure that there's enough flow. So I think in response to your question, I think that tenons really is the unifier. I think it's sort of the invisible that nobody talks about. We talk about the device. We talk about the operation, where to put things, but everybody forgets about that external resistance that's naturally there at the end of the operation once we're closing up.
And the amazing thing is that I think, just as Brian brought up earlier, even if you remove tenons as part of a revision, eventually a tenon cyst reforms. And people have tried doing trabeculectomy with tenonectomies. They don't seem to work any better. And so tenons is a problem that we haven't solved. And, people have tried throwing mitomycin onto tube cases, maybe hoping to get less of a tenon cyst or of thick walled tenons. That doesn't seem to help. We just haven't figured out what to do to modify tenons like we were able to modify the conjunctiva with anti-metabolites. So it is something that we don't talk about a lot because we don't know what to do with it.
Renee, before you have that question, I'm going to bring up an anecdote. I remember that first Zen that you did that was Aquasis then. It was an Asian woman. And I remember I just joined the faculty. We sat down, we looked at it. You're like, oh, look at this, pressure 10. I'm amazing. I was like, yes, Brian, you are. And then I remember the first thing I said to you was, okay, where's your needle? Because I remember seeing that bleb expanded, and under the bleb, it was hazy because it was basically hydrated tenons. Just like, you know, at the end of if you take BSS and you inject tenons, it'll turn it white. So it was just this huge hydrated tenons scaffold. It's almost like, you know, when you build a building, you have to have the skeleton set up first. And I was like, oh, this is going to guarantee to fail. This is just a setup. All the fibroblasts are going to come in. And then we looked at the Aquasis lady, and she says, no, it's not part of the trial. We can't stick anything in. And, you know, I think her pressure was like higher than it was to begin with. So yeah, I mean, tenons is some, you know, there's some secret sauce here that we don't quite understand, and it may be kind of the whole bleb unifying issue. Renee, sorry to interrupt.
Yeah. Just for the panel, is there any just preference for putting the valve in the pars plana? Is this a combination with I've done a couple with the retina people and probably expecting less of an erosion issue post-op. And just for Dr. Kubenz, I didn't quite get the reason why for less than 21, why you got a separation between the tube and the trab. What was the reasoning for that?
So for pars plana tube placement, I think that's a great place to put a tube. And if I'm bothered by recurrent erosions, there's nothing like a complete vitrectomy and getting that tube more posterior to prevent erosions. You know, it just does require, you know, a complete vitrectomy. I like the idea of sulcus placement too, because then the tube's further back, maybe preventing erosion. So if I get an erosion, I'll try to put it in the sulcus as part of the revision. But that's not as easy as it sounds. I mean, it sounds really easy, but you know, the tube doesn't always go where you think it is because you're kind of doing that blindly. You know, I haven't thought a whole lot about the second question is in primary TVT, patients with baseline pressures less than 21 don't do as well with tubes as they do with trabs. You know, I don't know if you guys have any thoughts on why that might be. It's kind of like really new data that I don't even think was part of the 1-year paper. But I don't know. What do you guys think about that? Like theoretically, tubes not doing as well with low pressures. Maybe it's just a 1-year phenomenon. I don't know. I don't think we have a good answer for that. But it was this very strong risk factor. It was only one of 2 risk factors for failure in the whole primary TVT study. One was randomization to tube, and the other was baseline IOP. Really big risk factor.
Is it possible? Depends on the definition of the success in the PTVT, because I guess it depends on what pressure you're looking at. For that particular criteria, maybe the trap is better. We know that the trap in 1 year can get a lower pressure than tube. So it depends on how you define it.
Yeah, that's a very good point. Yeah.
Question right here.
Dr. Francis, I have a question. We knew that doing trabeculotomy alone and not using antimetabolites will have a high failure rate. So this will happen for the Zen implant and Intercos too, because we are not using any antimetabolites for controlling the fibrous action of the conch. So what's the disadvantage? What's the advantage of using these implants in compare with not using the antimetabolites?
Okay, so first of all, I wanted to kind of give a historical perspective on Zen implant and how we were using it initially without antimetabolites. Now it's standard. You use mitomycin. Mitomycin is injected into the subconjunctival space at some point during the procedure. Some do it preoperatively, some do it during the beginning of the surgery, some do it towards the end. That's surgeon dependent. But just to show you that it really doesn't work that well without antimetabolites. I mean, you do need mitomycin for Zen just as you need it for trabeculectomy. And the InFocus is also using mitomycin as well.
So
this is just a follow-up question for Dr. On Dr. Law's topic about, I think it's challenging to look at different devices and studies and see and compare success rates, because it seems like we're defining things quite differently in different trials of what success and failure is. I'm sure people have thought about it, but is there a role in trying to come up with a consensus of what success and failure is such that there's more standardization between trials and people can look at them and compare them? Or is it just because it's difficult because of glaucoma?
It's not difficult. It's just nobody want to do it. That's all.
Well, I mean, WGA, the World Glaucoma Association, has criteria, and not everything always follows WGA criteria, but that was obviously been considered in the past, and effort's been put there. I had a comment, a consideration for Dr. Law, and also something that's a little bit of a misconception out there. Amount of flow and pressure. Okay, first thing is, in our eyes, because it's closed, it's actually a constant flow situation, meaning that like you have high pressure, low pressure, you don't get more flow if there's high pressure. It's always the same flow. The glaucoma and the high pressure and the normal person with low pressure, everyone's flowing the same. Why? Think about it. If you assume, first of all, first order principles, that production is always stable, if production is always stable at 2 microliters per minute, and you did surgery and you went from 2 to 3, that means you have more outflow than inflow at 1 microliter per minute. A couple hours later, you got a flat chamber. So, we obviously don't have flat chamber. So the reality is we are always constant flow. High pressure is just the same flow as regular pressure. You just have to push harder, which leads to, the whole observation about early aqueous suppressants. By that idea, I don't know, is it that it's like bad humor being delivered? Although the bad humor theory with TGF-beta is a long-standing one, it probably has a lot of validity there. But I wonder instead, it's the pressure difference. High pressure, not the aqueous being delivered, but having to push harder does something to make the hypertensive phase. And I don't know what your thoughts are about that.
I think you're totally right. It seems to believe in that's the pressure, not the flow. And the higher the pressure push the collagen tighter, and then the tighter the collagen decrease the diffusion, and then the pressure become higher. Then this keep going on and on and on and on. So that's why if the pressure goes up to around 12 or 13, if you don't act on that, the next 1 or 2 days you go to 24, and then go to 48, and it's really fast. So we tell people to start earlier.
So Don Minkler showed years ago in rabbits that one of the forces implicated in thicker and less permeable capsules over tubes is mechanical stress during capsule formation and even later down the road. So that may be due to movement, or, as you say, the pressure gradient pushing through as it's forming.
Any more questions? All right. Well, thank you everyone for finishing up with the more. Oh, one question.
Sort of an old question, but when the Ahmed valve first came out years and years ago, when the Ahmed valve first came out years and years ago, I thought that would make the barbette obsolete because it did the same thing and it had a safety valve, and yet it hasn't really quite worked out, and we still use both. One of the things that always bothers me when you compare the two is that you're sort of comparing two things. One is the valve and one is different sizes. Like one is 350 and one is 2. So I wish you could somehow compare the same, or do they with the same size plates, so you can really see what difference the valve makes, for example, as compared to the size of the plate.
So anyone want to tackle that? I think there was, does anyone remember the double plate Ahmed? So that was an attempt to basically double the size of the Ahmed. There's an accessory plate that you would attach onto the muscle like a double plate Maltino, and it's obviously gone, so it didn't work any better than a single plate. So I think size and surface area is important, but early exposure to aqueous with a valve device is also important. So.
Yeah, I think that's the debate we've been having with Ahmed versus Barvelts. Is it the larger plate size alone, or is there something good about, getting rid of the inflammation during that first 4 to 6 weeks before the Barvelt stitch dissolves that makes the capsule thinner and things work better? But I think, potentially both things are in play and very, very important.
Any other questions?
So we're going to break for lunch now, and we're going to come back at, 1:30 for cataracts and glaucoma.